All right, guys. So today we're doing immunodeficiencies. I added these like a slight change to the schedule. So tomorrow it's gonna be 3 hours. I know, but what I really did was it's gonna still be content from 4 to 6, but there's so many questions because again it's so much content. Because tomorrow is just kind of like everything else. Like it's literally just called everything else. So anything that's on your study guide that or objectives that we haven't covered yet is gonna be covered tomorrow. So it's just a lot of material, and I wanted you guys to see questions that you could potentially have based on the material. So I added literally just an extra hour for questions, but if you can't stay, that's totally fine. But I know it's a really long time, but just keep that in mind. So I did add that extra hour. Yeah, because I know there's gonna be a lot of questions. Okay, and then Friday is gonna be a review, and I know it's kind of annoying that the review is like a week before, like almost like a week and a half, well, like 10 days before your exam, but like I said, I'm going on vacation like the 11th to the 15th. So I didn't want to leave the review for the 16th and then you guys like stressing out. So it is a review, but hopefully it'll still be recorded and then you can actually do the review if you need to like later or do it again. And I'm pretty much going to go over transplant rejections and transfusion reactions again because I think that they just need to be hammered in. But let me know if there's something you really want to go over again. And I can just add like literally a quick slide on it, not like a whole thing. Like this with the negative and negative selection and stuff. Let me know if you need to go over something again, I'll add it to it. And then we'll just go into a bunch of different types of questions. Okay. I threw in some OMM. Like I said, last year, this was like right before the exam. So people had been studying, like at least a little bit had been studying OMM. So just to remind you that that's a thing that exists. And then next week, probably after my final on Tuesday, I'm going to email out a PowerPoint with all of the questions from all of the sessions in just one giant PowerPoint. So you can just go through them, see which ones you need to do again and whatnot. And the answers will be at the end, so it won't give anything away if you like open it up and you see like you won't see stars and stuff. Okay. And then reminder, oh yeah, I have the exam May 10th. We'll be on vacation. So that's why I'm doing this review tomorrow. So again, anything you want me to review, send it to me before this Friday. Because again, I don't know how much I'm going to be on my phone when I'm on vacation. Okay. So I wanted to include this in the recording just to remind you guys, like, yeah, I'll be kind of away on vacation. Okay, cool. So now immunodeficiencies. So we're going to talk about we're going to talk about direct and indirect Coombs test. This is actually one of the lab techniques that Dr. Milani has on your objectives list, but it goes really well with blood typing stuff that we did yesterday. So it's kind of like a continuation of that. And then I'm going to talk about what a respiratory burst is. So like this is just what oxygen dependent killing of organisms are. And then we're going to go into the immunodeficiencies. Okay, so if you guys have ever seen any like prep work on immunodeficiencies, we'll talk about them. Hopefully it'll be like it'll make sense at this point. I'm like, oh, this receptor's missing, so that's why you see these symptoms. That's why I kind of put this like last. And then at the very, very end, this was requested from last year's class, but so I kept it in there. I think it's good. Just a review of some CD markers that we have to talk about. So like remember back in the day when we talked about like NK cells doing ADCC, antibody-dependent cell-mediated cytotoxicity, and they used their CD16 receptor to do that, and CD16 on NK cells is the Fc gamma receptor. So just like a little, it's like one slide on all the important like CD markers, and then what interferons are. So interferons kind of come up a lot on in practice questions and whatnot. So just kind of wanted to introduce that concept and then questions. Okay. So next is the direct and indirect Coombs test. So these are examples of type 2 hypersensitivity reactions. So a principle overall is when you guys see any lab test, and this is true moving forward, if there's direct in the name, so again, like a direct Coombs test, a direct immunofluorescence, direct anything, you're trying to look for the presence of an antigen. So something that's like foreign on a cell surface, that's what the test is detecting. So if you have a positive reading with a direct test, that means antigen is there, okay? If you have a lab test that has indirect in the name, you are trying to detect the presence of antibody. So again, indirect immunofluorescence, indirect whatever, indirect Coombs test, that's what you're trying to do. You're trying to detect antibody. So it works for any of these lab tests that have direct and indirect in the name, but it's going to work here with the Coombs test. Okay, more things before I can explain the Coombs test because it's kind of complicated if you don't kind of understand this little concept right here. So in order to get noticeable clumping with antibody tests, it's not enough for the antibody to bind the antigen. So you won't get clumping if this antibody just binds to this antigen. That's not enough to cause clumping. Because again, what you're trying to see with these tests is you add like a little reagent to the slide, and you have to see if like little red cell little clumps happen. So like little clumps like this. You won't get clumping if it's just one antibody recognizing one antigen. What gives you clumping is when all of these antibodies kind of come together. That's known as agglutination. And I think of like the glue and agglutination as being like glue. They're like holding these cells together. So for example, here's like, let's just pretend this is a red cell. I know it's blue, but let's pretend it's a red cell. Here are antigens that we're trying to detect, okay? So we're trying to detect these antigens, but we're trying to see if they're there. We're trying to see if they're on the surface of this red cell. So we add a certain type of antibody that should, in theory, recognize this antigen. And then this red cell and this red cell are going to both be recognized by these antibodies. And then these are going to kind of come together and agglutinate. And then that's going to cause clumping. And imagine there's tons of red cells in here. So there would be like one here, one here, one here. Like that's what's kind of causing the clumping. Okay. Oh, all right. Oh, I forgot I did this. Okay. Well, I'll talk about this. So this is like, I made that specific for Coombs. So I'm going to show that exact image in a second. So for a direct Coombs test, think, did the patient make antibodies that are now coating their own red cells? So for example, is the drug that a patient took now acting as a hapten? So we talked about yesterday with penicillin, especially. So we have a red cell. Penicillin like loves to like just kind of like absorb onto the membrane, onto the red cell membrane, and it acts as like a little hapten, so it can elicit an immune response. So when you do a direct Coombs test, you're trying to detect this antigen on the red blood cell. Make sense? So in theory, you would add something that can detect this antigen. For indirect Coombs test, now we're interested in antibodies. So did the patient make antibodies in general, but they're not coating the red cells. These antibodies are not coating the red cells. We're just curious if there's antibodies in the system. So we're, again, indirect, you're trying to look for the presence of antibodies. So a good example of an indirect Coombs test is, did an Rh negative mom make anti-Rh antibody? When mom makes anti-Rh antibody, it doesn't coat her own cells. That would be counterintuitive, but it's there, and that's what you're kind of looking for in these patients. And I have images to show you what all this means, but here are some of the reagents you need to do a Coombs test. So this is a anti-human globulin, so sometimes it's called AHG. This is an antibody against human antibodies, which sounds confusing, but let's say like here's IgG from me, and then I'm a human, right? So we add this reagent, we take a little drop of my blood, we add this human anti-human globulin, and it's gonna recognize the FC portions of it's gonna recognize all of these antibodies because these are human antibodies. So it's basically anti-human antibody. It just is kind of weird, but that's what AHG is. Then you're going to use reagent red blood cells. So reagent red blood cells are like red cells that have certain antigens on their surface. So for example, if we're testing a red cell, if we want to see if someone has anti-A antibodies, let's just say, we want to see if someone has anti-A, we would use red blood cells with A antigen on them. So it would be on here like they're called Coombs cells. These red cells, just this vial would contain red cells with the A antigen. So that's an example, and they exist. There's like ones with D antigen, ones with B antigen, etc. Okay. And then, so these are the reagents you use like in the lab with you. And then from the patient, what you do is you take their blood, you spin it down. So you use a centrifuge, you spin it down. It basically, centrifuges use gravity to like pull down denser things, and then like you can separate out layers. So blood itself is very, very dense. Think of all the cells in there. So it's going to have the red cells in there. It's going to have some white cells like a little bit above it here, which you can't really see. But then there's going to be serum. Serum is where antibodies are. So the clotted blood here, this is where the red cells are, and then this is where the antibodies are. So what you do with these tests, if you're interested in looking for antibodies, you take the serum. And then that's what has the antibodies, or maybe it doesn't have antibodies. Maybe we're trying to see if an Rh negative mom made anti-Rh, and maybe she didn't make anti-Rh. So that's this is like the test sample. You're using the serum if we're looking for antibodies. Hopefully it'll make sense with the pictures. So with the direct Coombs test, we're going to just say, so a positive test means that they have an antigen. So they have a specific antigen that's now being bound by antibodies on the surface. So this is a type 2 hypersensitivity. We talked about this yesterday. This would be like an anti-D binding a D antigen on like a cell. A negative test means that the patient does not have antigen that's bound by anything on its surface. So for example, here's your direct Coombs test. So again, this would be like patient has antigen bound by antibodies. So again, we're looking for the presence of a type 2 hypersensitivity. So think of this as being penicillin again. So here's your red cell, here's penicillin. Now I made antibodies against penicillin, and they're going to be coating my red cells. It's going to cause like hemolytic anemia, all that stuff. So now we want to confirm it. We want to see if that's what's happening. So this is what's in the blood. We can't see this, so we don't know that this is what's happening. But let's say this patient is positive. She does have like penicillin on her surface, and now she has the antibodies bound to it. Remember, this doesn't cause clumping because you don't see clumping if it's just like, if they're just kind of like one antibody recognizing one antigen. So what you do is you add AHG. And anti-human globulin it has this really weird structure. It kind of looks like IgM. It just looks like a giant branching structure. And every single one of these recognizes FC of IgG, if it's like a human in humans. So every one of these can recognize an IgG. So what you get is you get something that looks like this. This is what's causing your clumping. Okay, so that's your visible clumping. So when you get the readout, this is all you're seeing. So you can assume, because you see clumping, that this is what the patient's blood looked like to begin with. But let's say we go through this process, there's no visible clumping. So again, we have the patient's blood. We don't know what it looks like. We want to see if penicillin may be absorbed to the surface, and then the patient made antibodies against it. When we add the AHG reagent, nothing happens. There's nothing for AHG to bind to. There's no antibodies on the surface. There's no antibodies that are recognizing antigen on the surface of the red cells. This is direct, and we're going to talk about indirect next. But direct, there's only one step. There's only one thing you're doing. You are only adding AHG. It's direct. I'm just directly adding it. Okay? Okay. Indirect is kind of the same principle. We're trying to see if there's presence of this antibody or not. So again, a very good example of indirect. Just think of like seeing if an Rh negative mom is making anti-Rh. So this is what I use as the example. So now we took the serum. So we took the serum out, and we're going to look to, like, so we can't see this. Like, we have no idea that these are in her serum, but we're going to use reagents to see if we can figure it out. So in this example, we're interested in did mom make anti-D antibodies? So what we're going to do is we're going to use those reagent cells, those Coombs cells, those reagent red blood cells that we know have D antigen on them. So we add those in there. If these are in her serum, they're going to bind. And again, this kind of looks like the starting point of the direct Coombs test. And then from here, you have to add AHG so you can see clumping. And then in this instance, if you see visible clumping in this instance, then you can assume that, yeah, she had these antibodies in her serum to start. Because again, we are adding this, so we know what this contains, and we're adding this to see if there's going to be clumping. But let's say that mom didn't make anti-D antibodies. So when we get a sample of her serum, there's nothing there. But of course, we don't know that yet. So we add our checks. They're called like reagent red blood cells or check cells, Coombs cells, whatever. We add the reagent red cells with the D antigen. So this is what happens. Nothing happens at this point. We add AHG, and you get no visible clumping. Okay, so this is kind of how and then this is called indirect because it's like you have to do a step before adding the AHG. So we're adding the reagent red blood cells. So there's like an extra step with indirect versus direct. Does that make sense? Does that make sense? And then I'll show you this here, and then we can talk about if anyone's still confused about this. But so again, direct. We're trying to detect for presence of an antigen. So when we're talking about blood specifically, we're trying to see so if the antigen absorbed onto the red cell, did we make antibodies against it? Or do we have a type 2 hypersensitivity, basically? So again, we're looking at the patient's red cells. These are from the patient. All we're doing is adding AHG, and then we're looking to see if there's clumping. If we have clumping, then she does have this type 2 hypersensitivity going on. If there's no clumping, then she did not have this type 2 hypersensitivity going on. Indirect, now we're curious about just the serum. So we're just curious if the patient's making antibodies. We really don't care if they're coding we really don't care if they're coding anything. We're not even looking at her red cells. We're just looking at her serum. So we're looking at her serum. We add the reagent red cells that we know have this antigen on it for whatever antibody of interest we're curious about. We add AHG, and then if we see clumping, this is a positive indirect. We know that she's making antibodies. This could also work for, let's say you have someone with type B blood, like up here, we know someone has type B blood, and maybe they were exposed to anti-B antibody, or they have anti-B antibody somehow, or something like that. We want to see if there's a type 2 hypersensitivity reaction occurring. With here, we're just curious if she has antibodies. This is, again, how you do like cross-pat. This is like, yeah, so is this how you test someone's blood? This is how you type someone's blood. So again, when I worked in a blood bank lab, I had to do both of these. I had to do the direct to detect what type of antigen do they have on their surface. Are they type A? Are they type B? And then you kind of confirm with an indirect. So if they're type A, they should have anti-B antibodies in their serum. But this is exactly how you type someone, and you go through and you do this process. You're like, oh, like I see clumping. It's probably A positive or whatever. So it's kind of cool. So you can use red cells with A antigen, red cells with B antigen, red cells with D antigen. Oh, I see clumping here, here, not here. And then you kind of go about like that. So these are used to type blood, or they can be used to like diagnose like type 2 hypersensitivities, or again, like if Rh neg mom is now been sensitized to D antigen and now she's making anti-D. Does that make sense? Do you guys have any more questions about this? This is like kind of confusing to wrap your head around, I feel like. But just let me know. We can talk about it later as well. I did throw in some questions on it, so, but okay. Oh. Can you explain how you use direct to type blood again? Yes. So with that, you're just adding, it's kind of like the opposite. So this is not showing typing blood. This is more so for like pathology state. So is there antibody coding the antigen? But if you use it to type blood, we have our red cell, we have A antigen on our red cell. And what we do is we're going to add, it's like the opposite of check cells. It's like check serum. So you add Coombs serum, which like you can have anti-A serum, anti-B serum, anti-D serum. You add it to the patient's blood. You add AHG, and then you see if there's clumping. No problem. Yeah, so this is like a very specific example to look for pathology. Both of these kind of are the ones that they gave you. But again, you can use this for blood typing. And again, direct, we're trying to directly see if there's an antigen on the surface. And indirect is like, okay, is there an antibody in the serum that we're curious about? Okay. Cool. Okay. So next we're going to talk about the respiratory burst. So what is the respiratory burst? If you guys have done some of the immunodeficiencies yet, you know that there's one of them is an issue with the respiratory burst. So another name for this is oxygen dependent killing. This is going to come up again with pathoma next year when you do your immuno review with pathoma. And he really talks about this because this is a really big this is like a biochem type thing. So with phagocytosis, so remember our phagocytes are neutrophils, macrophages, dendritic cells. Eosinophils are like baby phagocytes, but neutrophils are your big guy. Neutrophils are big phagocytic cells. So remember, phago means to eat, so it's literally just engulfing bacteria. It's just engulfing whatever's there, and then it digests it. So basically the respiratory burst is how does the phagocyte digest the bacteria? I know we kind of briefly talked about how with the phagosome, then the lysosomes come in and they fuse and then they die. Now it's like how exactly is it doing that? The respiratory burst. So this you should 100% know the order of this happening. And the reason why it's important to know this order is because the pathology state that involves the respiratory burst has an issue. It's like very specific to this order. So within the lysosome, so remember that the lysosomes are going to come in. So if I drew, I guess it's not, I expanded the wrong figure. It's okay. So if I drew the lysosomes like this, they're going to fuse with this phagosome. And then this is what's happening once that lysosome kind of fuses with the phagosome. This is like what's going on in the lysosome. So what's happening at first, this is oxygen-dependent killing. So oxygen's important for this process. So oxygen's going to be there in the lysosomes. It gets converted to what's known as superoxide. So superoxide, this is basically an oxygen-free radical. So here's your little free radical sign, throwback to Origo. But so superoxide, oxygen-free radical. Then from here, it gets converted to hydrogen peroxide, so H2O2. And then it gets converted to hypochlorite, so HOCl, which is also bleach. So this is literally bleach, hypochlorite. So from here, these are all kind of examples of free radicals. So superoxide's a really good free radical, but then hydrogen peroxide is a really good free radical, and then bleach is a really good free radical. So all of these free radicals in general can cause damage. They can just cause damage. So they're known as reactive oxygen species. So you might see this terminology being thrown out just in all blocks, not even just Immuno. But if you see ROS or reactive oxygen species, maybe if you're reading and you see this, this is what they're talking about. And these aren't the only 3 reactive oxygen species, but usually any free radical that has oxygen in it is going to be a reactive oxygen species. And these are the guys that can cause issues. They actually think that free radicals are what cause us to age. So there was a big push back in the day to look at like how do we get rid of these free radicals and like try to get antioxidants to kind of get rid of them and stuff. So but it didn't go anywhere. But these can cause issues, but this is fine because they're contained in the lysosomes. Like we want them to cause issues, right? When they fuse with the phagosomes. So it all comes from oxygen, though. Oxygen kind of turns into this it turns into superoxide, then hydrogen peroxide, and then hypochlorite. And you can have different types of free radicals from oxygen. Like it's not like oxygen only forms into superoxide. Oxygen can also form into like a hydroxyl free radical. It's a really big circle, but just keep that in mind. So when you're moving forward, you're not like, no, oxygen always goes to superoxide, but in this instance, it does. Okay. So here are the enzymes that do this conversion. So from here, oxygen gets converted to superoxide by NADPH oxidase. Then superoxide gets converted to hydrogen peroxide by superoxide dismutase. It's also referred to as SOD. And then hydrogen peroxide gets converted to hypochlorite or bleach by myeloperoxidase, which is called MPO. This is specific to neutrophils. So myeloperoxidase, this is like what is in these granules within neutrophils. Okay, so those are the enzymes. So some microfacts to understand to kind of help you with the one that we're going to talk about that affects the respiratory burst. All bacteria can generate hydrogen peroxide. They don't do it through this process, but they can generate hydrogen peroxide. They can do it. Okay? Some bacteria, however, are known as catalase positive. And when you guys do your sketchy videos this summer, there's always going to be a cat, like literally a picture of a cat in every sketchy that the bacteria is catalase positive. And it's really important to know which bacteria are catalase positive because they're going to cause issues with one of the immunodeficiencies. Okay? I'm getting ahead of myself. But if a bacteria is catalase positive, they can take hydrogen peroxide and convert it. So this is catalase, so it's another enzyme. Lots of enzymes, right? Thought you were done with enzymes. So they can take hydrogen peroxide, use catalase enzyme to convert it to H2O and water. Nope, H2O is water. H2O and oxygen. Neither of these are reactive oxygen species. Oxygen can generate reactive oxygen species, but now we're all the way down here. It's not going to go back and start this process over again. So basically what I'm trying to say is a bacteria that basically can't, a catalase positive bacteria can utilize this hydrogen peroxide and just convert it. So it can kind of like hide from this pathway because it's like, oh, I'll just take the hydrogen peroxide and convert it to H2O and water. So with this idea of all bacteria can generate hydrogen peroxide, right here, this is a bacteria that's producing hydrogen peroxide. The phagocyte can be like, oh, I can steal this. Like, let me just steal this. And instead of like me making it, And by this, I mean the phagocyte. I mean like the lysosomes, like the lysosomes itself. They can steal this hydrogen peroxide that the bacteria is making, so they don't have to go through this process. They can like save their oxygen for later if they want. So they take the bacteria's hydrogen peroxide and they convert it to bleach. So they kind of come here and they convert it to bleach. And then bleach is the one that's actually causing the digestion of the microbe. Like this is the one. That's why they always say to put bleach in stuff, because like if you really want to kill something, because bleach kills bacteria. So even if something goes wrong during this stepwise pathway within the phagocyte, so even if something goes wrong within this pathway, the bacteria that's still producing so actually I think I meant to say, so if something goes wrong in the stepwise pathway within the phagocyte, the bacteria that have catalase can just break down hydrogen peroxide into H2O and oxygen. So catalase is just an enzyme that some bacteria have and others don't. You need to know these 5 catalase positive bacteria. So it's Staphylococcus aureus, so Staph aureus, Aspergillus fumigatus, Burkholderia species. So like one of the most common Burkholderias is Burkholderia cepacia. And the reason why Pseudomonas is on the same line is a lot of the bacteria, a lot of the Burkholderia bacteria are getting renamed to Pseudomonas. It's kind of annoying. But a lot of the times it's like in questions at least, they'll refer to it as Burkholderia. Serratia, marcescens, and nocardia. These like last few are kind of like weird. So if you see them in a question, they're probably trying to get at like this process, like they're trying to get at this. Staph and Aspergillus are a little less common, but if you see multiple, and again, we'll talk about like why I'm referencing these types of bacteria, but they're going to be like clues that they're talking about this process, this catalase positivity. So when does this become a problem? Because basically bacteria can produce their own. So if this is an issue, like if this goes wrong and if this enzyme goes wrong, let me move it out of the way. So if this enzyme goes bad and this enzyme goes bad, it's fine. The phagocyte can just take the bacteria's H2O2. It doesn't need superoxide and then to make its own hydrogen peroxide. It can just steal the one that the bacteria make. And that's like why I'm saying all bacteria can generate hydrogen peroxide. So this doesn't seem like it should ever be an issue. Like something going wrong with this pathway should never be an issue, because it seems like the phagocyte can just take H2O2 and make bleach regardless. So when does this become a problem? This is going to become a problem with these catalase positive bacteria. So stay with me. Here's what I mean by this. So let's say something goes wrong in this pathway. So we can't make our own hydrogen peroxide, the phagocytes. Not a big deal, because again, like I said, all bacteria produce H2O2. So it's going to start producing it, like these orange guys. They're going to try producing it like, oh, let me get out of here. The phagocyte's going to be like, cool, I don't even need these two. I can just take it and make bleach from here. I still have my myeloperoxidase. Myeloperoxidase isn't even in the lysosomes. It's in these granules. So it's like, great, I can use myeloperoxidase. I can convert it to bleach. We're good. But some, not all, some bacteria, as I mentioned, those five big guys, they're catalase positive. So as soon as they produce H2O2, they can be like, psych, and then they can convert it to H2O and oxygen and O2 because they have catalase. So this is in the bacteria, but they're going to produce H2O2 and then they can release their catalase enzyme to actually convert it to water and oxygen. So now this can't happen. So if something goes wrong here, let's say we don't have this enzyme, we don't have this enzyme. So if something goes wrong and now we have a catalase positive infection, so there's really no way that we can, the phagocyte can get H2O2. It can't make it. It can't steal it from the bacteria anymore because the bacteria is now converting it into water and oxygen. So this is where it becomes an issue. So these phagocytes, these neutrophils, cannot kill the microbe if there's a defect in this respiratory burst pathway and if the microbe is catalase positive, because these bacteria learn very quickly that, oh, they're trying to use this, I'm just going to convert it to water and oxygen. And you guys will see this summer, like bacteria are really smart. They're really good at hiding from our immune system. So this is like one of the mechanisms that they can employ. Again, usually in people that have a defect in this respiratory burst pathway. And then we're going to talk about this too a little bit when we talk about the immunodeficiency. But these, at least one of these tests, I think, was on your objectives. I forget which one, but I think it's MBT was on your objectives. But both of these are tests for this process. So when I say, how can we test for the respiratory burst? How can we test for, oh my gosh, how can we test for this process? So how can we test from oxygen going to superoxide, going to hydrogen peroxide, going to bleach in the phagosome? So again, we're not stealing, like for these tests, we're not stealing hydrogen peroxide that the bacteria is producing. We're trying to see, like, I guess, like the endogenous production of these reactive oxygen species. Is that happening? So there's two tests that you can do. They work exactly the same way. It's just what color they turn is different. So the first one's called dihydrorodamine, so DHR. Dihydrorodamine, it turns green. And then NBT, or nitroblue tetrazolium, it has it in the name, which is very nice of it. It turns blue normally, but these tests work exactly the same way. But what's weird about these tests, and don't get got, please don't get got. Make a little note. Say, Christina says, don't get got here. These are really weird. And if you're doing these questions really quickly, you're going to get got. So just please read. If there's a question about NBT test or dihydrorodamine and they give you the test results, just take an extra second and read it. And remember, like, this slide right here. So the results for these tests are not, they have nothing to do with the pathway. So a positive NBT test or a positive DHR test has nothing to do with the respiratory burst pathway. A positive result just means that there's color. So if I have a positive DHR test, that means I see green. If I have a positive NBT test, that means I see blue. That's normal. You want to see colors. Like normally in normal people that don't have defects with the respiratory burst pathway, you do these tests and they turn green with DHR and it turns blue with NBT. So if they say, again, like I'm just telling you, because you're going to get a bunch of lab tests, especially moving into second year, and it's going to be like DHR test is positive. That doesn't mean, because usually, positive test is like, oh no, like I have COVID, right? Like I'm positive. Oh no, I have COVID. This is like positive test is like, oh, it's normal. Or if they say like NBT test yields color, it's normal. So just keep that in mind. A positive test is not positive in the sense of like a lot of lab tests. It's like positive means there's color, that's normal. So if there's no color, so they say absence of color or no color after DHR or NBT, or a negative test, that's bad. So a negative test is bad. It's abnormal. There is no color. So positive and negative is referring to the presence of color. It's really annoying. I don't like that that's how it is. And you don't have to use both of these two. You can, like, a lot of the times in the prompts, it's going to be either DHR or NBT. You don't have to do both. I've actually never seen a question with both, but just know that they do the exact same thing. It's just the colors are different. Okay. Good? NBT? All right. So kind of snuck in some lab tests there. Okay, so principles before we go in, because I'm all about principles, so you're not memorizing. But if you're missing T cells, so a lot of these immunodeficiencies is going to be like, okay, the patient's missing B cells, or the patient's missing T cells, or they're missing both. If you're missing T cells, remember T cells are super, super like critical in fighting off your intracellular infections. So viruses are the main ones. You should always be thinking viruses as being intracellular. Parasites are intracellular because they also live within cells. And then some fungi, it's like not, for first year, this is fine. Like viruses, maybe some parasites, but think T cells with that. And then if you don't have T cells, your paracortex within the lymph nodes is going to be smaller. Okay. So it's going to, like, they're going to be talking about how, like, maybe the paracortex of the lymph node just seems smaller in this patient. And that should be kind of like a little indication that it's a T cell issue. If the patient's missing B cells, can't fight off exogenous infections. So always, always, always kind of think about bacteria with exogenous infections. Fungi are weird. Some fungi can be exogenous, some can be endogenous, but bacteria are the main one. So it's like viruses with T cells and then bacteria with B cells. And again, fungi, I have some examples of fungi tomorrow, and we'll talk about some of the ones that you should know, like with immunocompromised patients. But regardless, if the patient's missing B cells, the follicles within the lymph nodes are going to get smaller because that's the B cell zone. Sometimes they say that, sometimes they don't. Sometimes in questions, they're just like, oh, the lymph node seems smaller. And you're like, well, that doesn't help me. But at least you know it's B or T cells, which is good. But specifically, it's paracortex for the T cells, and then the follicles are going to get smaller for the B cells. So moving forward with all of these disorders, with all these immunodeficiencies, immediately kind of establish, is this an innate issue or is this an adaptive immunity issue? If it's an adaptive immunity issue, is it a B cell issue? Is it a T cell issue? Or is it both? If there's a specific mutation, a lot of the times with the adaptive immunity ones, there's a like a driving mutation. So know what that mutation is, because straight up in questions, they'll be like, there's a mutation in this gene. And you're like, cool, I know exactly what this disorder is. And then how it presents. Unfortunately, what's an issue with a lot of these immunodeficiencies is they can kind of overlap with presentation, because some of them have T cells are missing as like a part of it, or some have B cells missing as a part of it. So it's going to be like recurrent infections. And you're like, okay, well, recurrent infections doesn't tell me much. So just keep in mind, there's going to be like little things, and I tried to highlight at least like what more important presentations are. But it's just something to keep in mind, okay? Keep this in mind if you're ever like stuck between a few. Okay, so we're going to talk about DiGeorge syndrome first. So I put on here for you, it's an adaptive immunity issue. Specifically, it's a T cell deficiency. So DiGeorge syndrome, T cell deficiency. This is something with, again, remember how I kind of mentioned like day one in the anatomy one, seems like so long ago, right? The anatomy lecture where I said the thymus develops from the third and fourth pharyngeal pouches, and that's just like an embryo thing. It's just like a fun fact. Well, in DiGeorge syndrome, it's a mutation that stops the third and fourth pharyngeal pouches from developing. So you never make a thymus. You just literally do not make a thymus. It doesn't involute, like they don't have it, then it involutes. They never make it. This is the exact mutation. So this is saying on chromosome 22 at the specific location of 11, there's a deletion. And this is what tells the third and fourth pharyngeal pouches not to develop. And the consequence of this is you do not make a thymus ever. So how it looks is patient doesn't have a thymus. So no thymus. They call this thymic aplasia. So again, aplasia, it just never formed. Absent parathyroid glands, that's just like another, it helps with the mnemonic later. But parathyroid from endo, this is how helps to make PTH, and PTH is what helps with calcium. And I only mention this, and the reason why is because the parathyroid glands also kind of come from these pouches, but again, you don't have to know embryo. But the PTH helps with calcium maintenance, and I mention this because one of the symptoms of this has to do with calcium. But so again, symptoms. Absent thymic shadow on chest x-ray. So remember I said like a lot of these are going to be if you don't see a thymus in a young, infant up to the age of 3, that's abnormal. So you'll see absent thymic shadow on CXR. You'll see cardiac defects, again, because the calcium's all messed up. And again, low PTH leads to low calcium. So the mnemonic is catch-22. So it's everything we talked about. Cardiac defects. Abnormal facies. This is going to be present in a lot of immunodeficiencies, but you can remember it for the mnemonic. T-cell deficiency, cleft palate. I think that falls in abnormal facies, but it's fine. Hypocalcemia. Again, we don't have PTH, so we don't have calcium. We can't really maintain our calcium that well. And then 22 for the chromosome 22 defect. So the exact mutation is 22q11. So here it was straight up from the anatomy lecture, the absent thymic shadow, there's no cell sign. So in this image, we see a cell sign, we see nothing here in this patient. It should be right here. And of course, they'll tell you like the infant is less than 3 years old. Okay, so that's DiGeorge. The next one is hyper-IgM. So hyper-IgM is an adaptive immune disorder. This is both a B and T cell issue, and I'll kind of show you what I mean by that. So you're thinking hyper-IgM, you're like, oh, antibodies, B cells, but it's the underlying cause is a T cell issue. Most commonly, it's due to a CD40 ligand deficiency. Do you guys remember CD40 ligand in B cell activation? It's what supplies signal 2 to your B cells. So signal 1 really is going to be like, yes, very good. So signal 1 is really going to be like, yeah, the B cell receptor is going to get activated. It's going to take it in. It's going to present it on MHC class 2 to a CD4 T cell. Here is the T cell receptor with CD4 binding to the antigen on MHC class 2. Signal 1, activation signal. Survival signal is going to be this T cell is applying CD40 ligand. And again, with B cell activation, this is signal 2. with T cell activation and any other type of activation with that, it's going to be CD28 on the T cell, B7 on usually the antigen presenting cell. But it can be like if it's an epithelial cell with MHC class 1, it can be present on like an epithelial cell. An infected cell is going to upregulate B7. Other names for B7, CD80/86. Okay. Sorry, I'm trying to review as much as possible. So B7 is going to bind, no, oh my God, I just confused myself. This is B cell activation. So CD40 on the T cell is going to bind, oh my God, CD40 ligand on the T cell is going to bind to CD40 on the B cell. This is signal 2 in your B cell activation. So this is your survival signal. This B cell survives. Now it's going to wait for whatever cytokines that it needs to tell it what type of antibodies it can make. So now it can class switch. So it can make IgG, it can make IgA, it can make IgE, it can make whatever this T helper cell tells it to make. So if you can imagine that there's no signal 2 in this process. So now we have no signal 2 here. So no cytokines. We really only now have like this signal 1, which remember, like they can really only get truly activated with both signals. But remember, B cells can also get activated without T cells. So this is almost like if you only see signal 1 without signal 2, it's almost like nothing, like it's like the B cell doesn't, you know what I mean? It's like, okay, nothing's going to happen from here. But the B cell can get activated on its own. Remember, you don't need T cells to activate B cells. B cells can get activated on its own by cross-linking its receptors, cross-linking the B cell receptors on its surface. But remember, when you don't have a T cell to activate a B cell, what's the only antibody you can make? It's low affinity, but hey, at least we're making some complement. We're going to get some complement out of here. IgM. Boom, hyper IgM. Isn't that beautiful? You understand the physio and then it just all makes sense. So that's why it's a CD40 ligand deficiency. You can't get T-dependent B cell activation. Thank you, Vanessa. Thank you. But you can't get T-dependent B cell activation. That's why you're only making IgM. You're only getting T-independent B cell activation. The only antibody you can make is IgM. This is an X-linked recessive deficiency. I put this on here, not so much, it's really not going to help you, so to speak, that much. There's going to be a lot more in the prompt that can help you. But some of them are going to be like X-linked recessive, for example. A lot of the times, the prompt is going to be talking about a boy. Because a lot of the times, X-linked recessive, it's coming from the X chromosome. Boys only have one X chromosome. So if there's one bad copy of the X chromosome, they're going to show disease. Girls really don't show X-linked. It can happen, but girls really don't show X-linked because it's a recessive disorder, so you need 2 bad copies, and it's really rare that both X chromosomes are going to have the same mutation. So this one kind of takes over in that instance. With guys, they only have 1, guys. With boys, they only have 1. So if it has a mutation, guess what? It's showing. So that's why it's just like little things to keep in mind in the prompts. So usually it'll be a boy. Again, it's not going to make or break you if it's like a boy. It's only gonna be a boy or girl, right? But it's just things to look out for. Okay, so we only make IgM. We get absolutely no class switching. So the patient's only gonna have IgM. So you order an antibody panel, only IgM. Boom, hyper IgM. But what's interesting is it's hyper IgM, so you're thinking it's a lot of IgM, but you can still see normal levels of IgM. Not sure why. Maybe it's like the B cells are just compensate. I'm not really sure. But just keep in mind, it can also just be normal. So what's more telling for this disorder is this, part 2. Decreased or absent levels of IgG, IgA, IgE. I know like a lot of the times we don't have much IgE or even IgA in the blood, but 75% of our blood should be IgG. So if we have like no IgG on this blood smear, that's hyper IgM. Has to be. Okay. Overall, just think about not being able to make any antibodies except IgM. It's low affinity. You can activate complement, so it's like not terrible, but you're just going to be more susceptible to infections, especially bacterial infections. Patient doesn't make germinal centers because we don't have T-dependent B cell activation. So where T-dependent B cell activation occurs is in the germinal center. So we don't have germinal centers. That's why the lymph node's like kind of tiny. And yeah. Okay. No CD40 ligand. So on here, like we kind of talked about, here's hyper IgM. No signal 2, CD40 ligand deficiency. B cell can only be activated by T-independent activation. Only IgM. No cytokines. I should have crossed this off too. No cytokines. Next is Shediac Hagashi. No clue if that's how you say that. Or Shediac Hagashi. No idea. If anyone knows how to say that, let me know. But it's this one, this weird sounding one. This is an innate immune disorder. So it's not going to be involving B cells, no T cells. It's going to be one of those other innate immune cells. So with this one, it's an autosomal recessive mutation. So that doesn't really help us with the if it's a male or a boy or a girl in the prompt. The gene defect is the LYST gene, LYST. This gene helps with microtubules, so like the development of microtubules. And specifically, what microtubule, you don't have to know like the functions of microtubules, but there are like two things that you should know about microtubules, at least with this disorder. The first is, remember when we get the phagosome, it's going to ingest like bacterias, and then it's going to get digested because the lysosomes are all around the cell like this. They kind of go to the phagosome and they fuse, and you get phagosome-lysosome fusion, and then boom, you can kill the bacteria. Well, this process of the lysosomes going to the phagosomes, guess what? Mediated by microtubules. So if we don't have this mediation process, they can't fuse. So there's no fusion of phagosomes with lysosomes, so you don't get phagolysosomes. And so that's part one. You get no phagolysosomes. Part two, a lot of these patients have albinism. I'm pretty sure Dr. Sitar with Pathoma goes into this a little bit more detail next year about like the specifics of albinism, but this is a microtubule mediated process. It's like with melanin, like melanin trafficking, like it follows microtubules within the body. So just think like you don't have melanin, you're going to have like, they're going to be albino. So like white hair, white eyes, white feet, just very white. And they'll say this in the prompt. They'll like talk about this in the prompt, like white features. They'll like mention that. And you also see giant granules within neutrophils because again, a lot like remember within the lysosomes and within the like with the at least with the respiratory burst. I know we're not talking about the respiratory burst, but these things have to traffic to get places to kill the bacteria. So this is like they're kind of being trapped. So they have nowhere to go. They can't like expel their contents. So they just get big. Like the granules just get big. So you might see what are known as giant granules. So this is like a good picture of Shediac Hagashi because you see like these absolutely giant granules. And again, it's just because like they can't get to where they need to go to expel their content. So they just get bigger and bigger and bigger. Are these patients susceptible to most bacterial infections or more so catalase positive? Good question. This is just most bacterial infections. Like these are kind of hard. So the reason why I think that it's like I didn't put something like that on here, like susceptible to bacterial infections. A lot of these, they're going to be susceptible to bacterial immunodeficiencies, right? So there's something wrong with their immune system where they're going to be susceptible. Almost all of these, you're going to be susceptible to bacterial infections. But the specifics of it are what they're going to help you answer the question. So almost in every single prompt on immunodeficiency, it's going to say like this child has recurrent infections or something. It's a good question about catalase positive, but it's not an issue with Shediac Hagashi. It's because like the granules can't even move. Like they can't even get to where they need to go. So the lysosomes themselves, which contain the respiratory burst reaction, can't even get there. So it's like a step before this whole idea of catalase positive. It's just every bacterial infection is going to be an issue. But good segue into this disease. So chronic granulomatous disease, or CGD, this is also an innate immune disorder. So no B cells, no T cells. And specifically, we're missing NADPH oxidase. So remember that this was the first step in the respiratory burst pathway. So this is what converts oxygen into superoxide. It's X-linked recessive. So again, think more boys than girls in question prompts. And basically, the patient can't undergo oxygen-dependent killing. So there's no respiratory burst in these patients. But they can steal hydrogen peroxide because, again, all bacteria can produce hydrogen peroxide. Not an issue. This really is not an issue because if they're infected with the bacteria, they're like, all right, let me just take the hydrogen peroxide the bacteria is making and I'll just use that. But if you have a bacteria that has catalase, which is that enzyme that can convert H2O2 to water and oxygen, that's where you get an issue. So, and then I mentioned like the 5 bacteria that you should know that can do this are listed here. Staph aureus, Nocardia, Aspergillus, Burkholderia, and Serratia. Serratia is weird. If you see Serratia in a question, they're going to be talking about this. Same with Burkholderia. This is such a weird bacteria. They're only going to be talking about it with this. Staph aureus, Aspergillus, Nocardia, those are a little bit more common. But what's going to give it away is the recurrent infections aspect of it. Like you keep getting aspergillus infections, you keep getting nocardia. And this isn't kind of like the, what is it? Like the late complement deficiencies where it's like they keep getting different types of meningitis, like over and over and over again. It's meningitis, meningitis, meningitis. This is like you can get Staph aureus one time, then nocardia the next time, then aspergillus the next time, and whatnot. So it can be any of, you're just going to see like the prompt might list out like 3 of these. And you're like, oh, interesting. These are all catalase positive. Okay. And then the MBT test and DHR test are both negative. Negative, remember, meaning no color. So this would be like it's negative, meaning they have the disorder. I know, I really hate that. I really hate that terminology. Like I'd be like, oh, the tests are negative. That's weird. No. MBT test, DHR test, both negative. You don't make blue with this test and you don't make green with this test. So that's abnormal. Okay. So here's this. So think NADPH oxidase deficiency. Oh, can't make this, can't make this, can't make this. But bacteria produces H2O2. Cool, let's steal it. And then we'll make bleach and everything will be okay. But catalase positive organisms can just convert it before the phagocytes can even get it. So you can't do this and you can't kill those bacteria. So you keep getting these recurrent infections with those 5 types of bacteria. And again, there's more catalase positive organisms. Like when you do the sketchies, there's a lot that have cats in them. But this is more so like the 5 that you're going to see with CGD. It's just the ones that they commonly ask about with CGD. Okay. Next is SCID. So SCID is like combined. So combined immunodeficiency. I think S is severe. I don't know. I forget. Everyone calls it SCID. So this is an adaptive immune disorder. And SCID, it's like combined. So I remember the combined, it's B and T cells. So B and T cells are deficient in SCID patients. There's 3 types of SCID disorders. So meaning there's 3 types of causes that can cause SCID. The first one, the most common one, is an X-linked recessive disorder, and it's an IL-2 receptor defect. IL-2 receptor, remember, that's T cell growth factor, IL-2. So IL-2, here is your T cell. It has IL-2 receptors on it. And then remember, when T cells get activated, they secrete IL-2 to themselves so that they can keep growing and whatever. So these receptors aren't here. It's basically like you can't activate T cells then because they just can't grow. Maybe you can activate it, but nothing's going to happen. They just can't grow. There's also one for an ADA deficiency, adenosine deaminase. I feel like I mentioned this like maybe last week, and I was like, oh yeah, look, adenosine deaminase, that causes an immunodeficiency if you don't have it. I'm not exactly sure why. It's just like, it's like another buzzword. Like if you see this gene is defective, it can cause SCID. And then the last one is a RAG mutation. So remember RAG, those are the proteins that help with VDJ rearrangement. There you go. So that's kind of why I mentioned those RAG proteins, because I knew that a mutation in them can also cause SCID. But the one they usually kind of stick to is IL-2 receptor defect. I have seen questions on adenosine deaminase deficiencies, but again, this is the most common one. So that's kind of the one that the question writers focus on. These are like your bubble kids. So I don't know if anyone's a Seinfeld fan here. I love Seinfeld. And the episode where George goes to like the bubble boy's house, he probably had SCID. The bubble boy probably had SCID. So they literally live in bubbles because they can't touch anything. They can't interact with people because even just the mere talking is too much. It's like too much immune stimulation. They don't have B and T cells. So these people literally live in bubbles. Well, now they kind of, I don't know if they have like a cure for it, but they kind of have ways to manage it better. So you don't see kids walking around in bubbles anymore. But literally back when this was coming out, they just put kids in bubbles because like, we don't know what to do. Like we don't know what to do. They keep getting infections. But those are your bubble kids. You can think of Seinfeld for the skids. Yeah, and then the bubble kid kind of attacks George. Very funny. But how it usually presents is such a severe disorder is it's going to be like, usually they're going to be babies that have failure to thrive, meaning they're not growing. They're just really, they just look sick all the time. And then they die usually from an infection of some sort. But the ones that survive, those are your bubble kids. But that's how it's just like very general. It's just failure to thrive, which is hard to, of course, pinpoint in a question. So again, they're going to give you a little bit something else to kind of help you figure out what's going on. They might even tell you like there's no thymus seen, so absent thymic shadow, no cell sign on chest x-ray, And like lymph nodes are really small with decreased germinal centers. So it's like they're telling you basically, oh, no T cells, no B cells. That's SCID. And again, absent thymic shadow, same exact thing, no cell sign. Okay. Okay. Next is X-linked hypogammaglobulinemia. And I guess this guy Bruton was like, that's too long. But it tells you everything you need to know in the name. So I kind of like the name. But usually you'll see it as Bruton's. So like Bruton's hypogammaglobulinemia or just Bruton's disease. X-linked, guys, right? So guys, X-linked. Hypogammaglobulinemia. Hypo, decreased. Gamma globulin, basically antibodies, gamma globulins. And then emia in the blood. So we have decreased antibodies in the blood. And it's X-linked. So males, think males. So this is adaptive immune disorder. Basically, it's a B cell deficiency. That's what's causing the decreased antibodies being in the blood. But I like remembering that it's Bruton's. It's also called Bruton's because it helps me remember the gene mutation. This is actually one they tend to ask a little bit more about in terms of gene mutations, is this one. So it's BTK. And I remember the B for Bruton's. I actually think it's, no, I don't think it's the B's for Bruton in this. I know the TK is for tyrosine kinase. I don't remember what the B is. It might be Bruton's. But regardless, we have this this BTK gene is mutated, X-linked recessive, so B cells can't mature. So something I wanted to put out here is there's no maturation of B cells. So, but if they did like a bone marrow biopsy or something, you'll see B cell precursors, but there's no mature B cells floating around in the blood. So they kind of go through a little bit of that B cell development in the bone marrow, but they can't mature. They can't get activated by antigen. They can't do any of that. There's not going to be B cells in the peripheral blood. So this is decreased in all antibody types. So IgM, IgG, IgA, and IgE. This is your key with the hyper IgM syndrome. You're also not going to have IgM. Remember with hyper IgM, you don't have to have increased levels of IgM. It's just IgM's the only thing there. Whereas with X-linked hypogammaglobulinemia, IgM's not even there. There's nothing there. There's no B cells, no germinal centers. A lot of the times they refer to this as having scant tonsils. Scant, whenever you see scant, it just means like little. It's just like another thing to look out for. Again, recurrent infections. So a lot of these have recurrent infections. But what's interesting is remember that babies have mom's IgG antibody for about 6-ish months. And then after mom's antibodies, because remember, IgG crosses the placenta and it kind of can confer like immunity to the baby for up to 6 months. So your baby might be born and they might be completely healthy up until like 8-9 months. And then they start getting sick just all the time. You're like, what is going on? And it's because those maternal IgG antibodies waned. So now the baby's on its own basically, and it can't produce its own antibodies. So even though it kind of is like it is a genetic mutation. So you're like thinking genetic mutation, shouldn't it present right away? But it's not because of this aspect. Mom's like antibodies are kind of conferring protection. That's a good question. So antibodies in breast milk, so IgA in breast milk, 100% those would help. So they would have to tell you like baby is being breastfed. Maybe you won't see as many mucosal infections. Because now the baby will have IgA. But they would have to tell you can't just assume in the prompt that the baby's being breastfed. They would have to kind of tell you, and it would have to make sense with like the lab results. So it would help, but you really need IgG. IgA doesn't really do, like IgA is like good, but for barrier protection. IgG is the one that, opsonizes, gets rid of, like activates complement, allows for phagocytosis and things like that. And yeah, and all that stuff. IgG is really important. So the issue with this really is no IgG, but yeah, just all of them are going to be down. But what's really cool about this is you can actually cure this with a bone marrow transplant. So it's been done and it has cured patients with this disease. So again, whatever this gene is coding for, you don't have to know the specific molecular biology. Whatever this gene's coding for, it's presenting in the bone marrow. So if you do a bone marrow transplant, you can basically replace that gene. Well, replace the protein that the gene would be coding for. And since blood and B cells come from the bone marrow, if you do a bone marrow transplant, now it's going to be coming from this new bone marrow. You'll get into it more with hem-onc, but it's actually really cool. Like if you get a bone marrow transplant, you actually can have like 2 different types of blood. Like you can have 2 blood types, which is really cool because the bone marrow produces blood. Yeah. So it's really cool. You can switch your blood type after a bone marrow transplant. But okay. Anyway, getting ahead of myself. All right. Wiskott-Aldrich syndrome. So some people just call this WAS, like Wiskott-Aldrich syndrome, and that's the gene mutation actually. So that's why people sometimes do that. This is an adaptive immune issue with both B and T cells, X-linked recessive. And with this one, you can't reorganize actin. So again, this is not microtubules. Remember, microtubules are also part of the cytoskeleton. Microtubules are for Escherichia Kagashi. That's going to be your albinism, and phagosome lysosomes can't fuse. Those are the 2 main things with that. For this, and you don't have to know why right now, you'll promise you'll go into like how actin goes into this stuff next year. But for this, you're going to see a triad of thrombocytopenia, which is decreased platelets. So platelets are going to be down. So how this would present in a prompt, how this would present in a prompt would be like patient bleeds, like just lots of bleeding, because they don't have platelets to kind of plug up when you get cut. Eczema. So just again, it's going to be a skin thing with actin, and then recurrent infections. But again, that doesn't really help. But if you see like increased propensity to bleeding with eczema, and then they're sick all the time, and it's like a young child, like that's your Wiskott-Aldrich triad. And that's really the most you need. That's really the amount of detail you need to go into that one. Selective IgA. So this is an adaptive immune disorder, specifically B cells. All right, so selective IgA. I kind of briefly mentioned this when we were talking about antibodies last week. This is where you only have a deficiency of IgA. That's it. You only don't make IgA. This is the most common. So a lot of you might even have selective IgA deficiency and not know it. And remember what I said is like the number one time that people realize that they have this is when they get blood. So when they get a blood transfusion and then they undergo this allergic anaphylactic type of transfusion reaction, which is mediated by IgE. Remember, it's mediated by IgE, but it's because the blood that they're getting has IgA in it. So they must have gotten blood in the past, made anti-IgA antibodies, and now their second time of getting a blood transfusion, they have this allergic anaphylactic reaction. So you really don't see too many issues with this because, again, like I said, IgA is more like barrier immunity, which maybe you'll get like some infections here and there, but you have normal IgG, you have normal IgM, you have normal IgE. What more can you want, you know? A lot of the times, too, something to keep in mind, an eye out for with these questions is, I know it's like selective IgA deficiency and you really can't make IgA, but rarely will it be like 0 on a CBC. So just look for like decreased levels. So if they give you a reference range for IgA, which is like 0 to 15%, well, not 0 to 15%, it's like around 15%, it's going to be less than what's normal. That's enough for selective IgA deficiency. But here's your buzzword with selective IgA deficiency. Minus like they might throw this in there trying to be like, oh, remember, it's like the most common cause of allergic transfusion reactions, Giardia. So Giardia, it's a microbe you're going to learn about in the summer, but it basically is you need IgA to get rid of Giardia, like absolutely necessary. And you get Giardia from like going to like water, like you're in the lake and now you come out and you're very sick after this. That's like recurrent Giardia. And then you have like really bad diarrhea. It's like a GI bug, but it shouldn't be an issue in people that have normal IgA. But if you don't, you're going to get recurrent Giardia. CVID I put on here because this is like, it turns into a cancer. I'm not going to say they're not going to ask about it, but I'm mentioning it here because you're going to go into it a little bit more with hem-onc, but it's not like one of the more common immunodeficiencies. But what it is, it's like, I think it's common variable immunodeficiency. So it's not like SCID, which is severe combined I think that's what the S is. But this is like, it's like variable immunodeficiency, and variable is literally the key word here. It presents so weirdly. It just presents like very different presentations of it. But the underlying issue is it's a B cell issue and it's diagnosed post-puberty. So this is how you're going to diagnose. This is how you're going to figure it out in a question prompt, because all the other ones usually are infants or babies or toddlers, like they're presenting a lot earlier in life. This is like someone that's like 18, 19, 20, and now they have like what seems like SCID, but you're like, SCID? Like, why are we diagnosing a 20-year-old with SCID? Like that should have been present like when they were born. We should have known that they had SCID. So if you're like thinking about like a 21-year-old that has SCID, you're thinking of CVID. And how it kind of relates to hemonc is these patients that have CVID, really high risk of developing B-cell lymphoma. Again, it's a B-cell issue. So it's kind of, you can even think of CVID as like a pre-cancer almost. Because it's like, I say really high risk, but it's almost like if you have CVID, you're going to develop B-cell lymphoma. Okay. IL-12 receptor deficiency, I kind of alluded to this when we talked about T cells last week. So here's kind of that slide from that. But it's exactly how it sounds. And it's not IL-2. So keep in mind, IL-2 receptor deficiency is one of the forms of SCID. It's the most common form of SCID, IL-2. And this is like your T cells just do not develop. Like even if they get activated, nothing can happen. Okay? Just no T cell activation, no T cells at all. IL-12 receptor deficiency. Remember, IL-12 is secreted from this whatever cell is activating the T cell. Let's just call it APC. This is probably dendritic cell. But remember, it secretes interferon gamma and IL-12 to turn the naive T cell into a Th1 cell. And then the Th1 cell secretes interferon gamma. And then it also secretes IL-2, which helps with CD8 T cell activation. So with this, if you don't have Th1 cells, you don't secrete interferon gamma and IL-2, you can't activate macrophages, and you can't activate CD8 positive T cells. If you can't activate macrophages, remember, this is like absolutely critical. This process here is like absolutely critical for getting rid of mycobacterial infections. So you're going to see disseminated mycobacterial infections over and over and over again, recurrently. But before jumping the gun and being like, oh, maybe they have an interferon gamma receptor deficiency, right? Because again, Th1 cells secrete interferon gamma, and then the macrophages have interferon gamma receptors, and that's what makes them, angry and then turn into like killing machines. So that can also cause the same thing. But it's just basically like it's the same kind of idea. We're just like a step before the interferon gamma. We're all the way back here. So we can't even get to Th1 cells to even have them secrete interferon gamma. So overall, you have a decreased Th1 T cell response, decreased interferon gamma is produced. Okay, so you can kind of think of this pathway and then think of these X's. So none of this is happening. So we don't have Th1 T cells, and we don't have activated macrophages, and we can't use these T cells to activate CD8 positive T cells. Okay. Hyper IgE, another name for this is Jobs. And basically with hyper IgE, this is interesting. So it's another kind of idea where it's like hyper IgE, you're thinking antibody, you're thinking B cell, but this is actually, it's kind of like the CD40 ligand thing causing hyper IgM. It's kind of the same thing. It's like the T cell is the issue, which is causing hyper IgE. So for example, there's the mutations called STAT3. Again, any of these mutations you should really know because they'll say it in the prompt, and then you don't even have to keep reading. Like, you know what it is. So these are good ones to know. But anyway, STAT3 mutation is going to cause no Th17 T cells. Okay. And remember, Th7 cells are really important for activating neutrophils. Not activating neutrophils for the respiratory burst, but activating, like getting neutrophils to the area where they need to be. So we see no neutrophil recruitment. That's kind of the big important thing that Th17 cells do. They get neutrophils where they need to be. So if we can't recruit neutrophils, when we have inflammation, not inflammation, but when we're trying to fight off an infection, we can't get neutrophils to the area. So you're going to see what's known as cold abscesses. This is kind of like your buzzword. A cold abscess. So again, when you think of the inflammatory response, you think heat, you think swelling, you think of those 5 cardinal signs of inflammation. Well, with this, it's like you can't get neutrophils to the area. You can't have like this idea of having heat because there's not going to be inflammation because no neutrophil. Inflammation, like by definition, is because of like the neutrophils coming to the area and then secreting the cytokines, and that's why you get like the the blood vessels dilating and then spreading apart and getting that swelling aspect so the neutrophils can come in. So you can still get an abscess, you can still get the swelling and whatnot, but they're going to be cold because there's no, like, neutrophils can't get there. I'm really emphasizing that, I'm sorry, but it's just, this is like a dead giveaway if there's a cold abscess. So I just kind of wanted to make sense of it with why, with neutrophils. You're also going to see these other really weird symptoms. So the STAT3 mutation is specifically affecting the Th17 cells, which in turn is affecting the neutrophils recruiting to the area, which is what's causing the cold abscesses. But then you can also see these other things. So elevated IgE levels, hyper IgE, elevated IgE, fractures from minor trauma. So think of someone that just kind of like fell, they were walking and they fall and they fractured their leg. Like, fracturing your leg takes a lot of effort. So you doing it really just from falling is probably weird. And also retained baby teeth. So these are kind of just like other cues that it's hyper IgE. But the underlying issue is a Th17 T cell issue. And it's a STAT3 mutation. And then we have chronic candidiasis. So candida, so it's Candida albicans, C. albicans, it's a fungus. So C. albicans, fungus. Again, we're going to talk about this a little bit more on tomorrow. Yeah, tomorrow. Candida albicans is weird. When you have, when you think of Candida albicans, you should think of both T cells and you should think of neutrophils. Specifically with the chronic form, it's T cells. And we're going to talk about like the localized form tomorrow. That's a neutrophil issue. But I'm going to have this basically again tomorrow. So don't be like, what is she saying about neutrophils? I'll talk about this again. It's just something they like to go after because they know, like, when people think Candida, they think T cells. But then I think people forget that neutrophils also help with Candida. So we'll talk about it tomorrow. But for this form, this immunodeficiency, chronic candidiasis, the one that's considered an immunodeficiency, this is a T cell issue. If you don't have T cells, you can't fight off Candida, which likes to be intracellular. Candida likes to be intracellular. It is extracellular. It can live on its own, but it likes to be intracellular. So you really need T cells to get rid of it. This is what you classically see this with an AIR mutation. So remember, AIR is the autoimmune regulator. It's the type of cell that's AIR positive that's presenting like different types of self antigens to the T cell for development. It's just like a thing that happens. So if you have an AIR mutation, a lot of the times you see chronic candidiasis with this. Yeah, so is this what individuals with untreated HIV often get? This is exactly what we're going to be talking about tomorrow. Great question. You can even put like a little review tomorrow to, like, after we talk, because there's two types of Candida that people with HIV can get. It's usually like it's only going to happen in autoimmune, in immunodeficient patients. So HIV makes you immunodeficient. So you're going to see Candida infections with HIV patients. This one, this chronic one, you need T cells. The localized one that HIV patients can get, you need neutrophils. But again, we'll talk about that tomorrow. But yeah, very good. So this you would see this in like an HIV patient. No problem. Okay. So how this is going to look in a prompt, and again, we're going to talk about this tomorrow. Like, you're like, what is she talking about? Scrape off white stuff from tongue. It's going to be like the white stuff on the tongue is Candida. It's like a yeast. You can see it. So it's going to be like these patients are going to stick their tongues out and it's going to be white, and then you can actually scrape it off. That's yeast. And then you do what's known as a KOH prep, potassium hydroxide. You just add potassium hydroxide to it, and you'll see under the microscope budding yeast. This is like the only immunodeficiency that you're going to see yeast, like budding yeast, on like when you look under the microscope. And the only one in terms of the strict immunodeficiencies, the ones in this lecture, that's going to be where you scrape something white off of the tongue. But we'll go into it a little bit more tomorrow if you're like, I still don't get it. We'll talk about it tomorrow. But just wanted you to be aware that fungi can also be present in these. Leukocyte adhesion deficiency. This is like my favorite immunodeficiency. I don't know why. I think it's so interesting. So leukocyte adhesion deficiency, LAD. Adhesion's the key word. So leukocytes, white blood cells, cannot adhere. Okay? So it's a deficiency of the white cells from adhering. So again, white cells, this is an innate immune issue. Specifically, it's a defect in the LFA1 integrin. The other name for it is CD18. And I have a slide, but remember with neutrophil chemotaxis, that's why we talked about that in like kind of excruciating detail, like back last week. So the neutrophil, when it comes to the site of inflammation, it marginates. It's following chemokines. So it's following either CXCL8 or IL8. It's following one of these cytokines, chemokines. These are your neutrophil chemotactic factors. So neutrophils are coming. They're going to marginate, and then they're going to roll. And remember, rolling is with selectins, because remember the selectin speed bump. So remember, if you're going along super fast and then you start going closer because you're going to make a turn, but you're still going too fast, the speed bumps are kind of there to slow you down. That's kind of what's happening here with rolling. And then once you get to the site where you want to get, you're going to bind. You're going to upregulate the cell adhesion molecules, the CAMs. And an example of a CAM is an integrin. So integrins are what's really important for adhesion. And again, it's kind of like the integrins are what grab the white cell and literally pull it through. And then that's diapedesis, or like extravasation, leaving the blood and going to the tissues. But you need integrins for the white cell to get. So there's no issue with the white cells. It's just kind of they're just missing this integrin, so they can't get grabbed, and so they can't leave at the site of infection. So why I'm kind of emphasizing this, that there's nothing wrong truly like overall with the neutrophils, is because think of, and this is why I think I like this one so much, because it's like counterintuitive, but you have to think of the symptoms of this like a white cell deficiency. But when you test the blood, you're going to see elevated white cell levels. And the reason why is because negative feedback. So you guys went through endo, you know all about the feedback pathways, but think of it as like, the tissues are like, hey, where are all my white cells? Can you send me more? And they're like, sure. So they try to send more, but it doesn't matter. There's nothing wrong with them. They just can't leave. But that's going to present as elevated white cells because they're all now here and they're just like clumped here. They're like, we're trying to leave and we can't. So it's going to present as like high neutrophils. Sorry, I keep saying white cell. It's specifically with PMNs because the LFA1 integrin is on your neutrophils. So again, think of this as a neutrophil deficiency, but with elevated neutrophil levels. Super weird. And that's because of this idea of negative feedback. And what's going to give it away in a prompt? It's like, because you can imagine neutrophil deficiency, okay, tons of bacterial infections, okay, like blah, blah, blah. But what's going to give it away is when babies are born, the placenta, the umbilical cord has to separate from like the baby's belly button, right? And usually so what causes that separation are neutrophils, are PMNs. So what you're going to see in the question, and this is, I should have put my buzzword B, this is only going to be caused by an LAD, is there's delayed separation of the umbilical cord. So the reason why is because neutrophils can't get to the area. They can't, basically what they do is they like eat away at the umbilical cord and then it basically falls off. So with this, they can't get there. So you're going to have a delay in that. It'll eventually separate, but it's going to be a lot later than it should separate. And that's what they'll kind of say. Like the umbilical cord took a very long time to come off. Exactly. The neutrophils have trouble getting got. This is the instance where they can't get got. Exactly. So they can't get got here and they can't get brought in. But again, look for this. This is going to give it away so easily. Delayed separation of the umbilical cord. So right here, and this was the exact same image that I put in when we talked about margination, rolling, and then the tight binding, and then diapedesis. Here's LFA1. So here is, again, it's kind of coming along. I think it already did margination back here. Now it's rolling, so it's going to be rolling along the selectins, which I forget now what these selectins are. Oh, I think it's this one. Yeah, I think these are selectins. Yep. So here's a selectin. It's like it's like interacting with like something on the white cell to kind of slow it down. Again, it's a speed bump. And then here's LFA1. This is what binds to the cell adhesion molecules that allow it to be brought in to undergo this process right here of diapedesis. So again, LFA1, another name for it is CD18. Is absent in LAD, no adhesion, neutrophils cannot exit where they're needed. So that's why you get elevated neutrophil levels. This is kind of like a big summary slide. I really like this. This is going to be like beautiful when you guys do hem-onc, but it pretty much shows everything. It shows T cell development, it shows B cell development. It's kind of like that tree, but then it shows you like where you have certain immunodeficiencies. So like, for example, if we have a deficiency here with the T cells, you're going to see chronic candidiasis, right? If you have an IL-2 receptor deficiency, which is the most common cause of SCID, you're going to have issues here. And then you don't get T cells here. DeGeorge, same thing, no T cells. So you can kind of follow along the T cell pathway and then I think I went the wrong way. You can follow along the T cell pathway and kind of see where all of these immunodeficiencies are acting. We kind of talked about a lot of these. So again, with the X-linked, with Bruton's, remember, you still see some precursors, but then along the way, something happens. And that's where you get the issue with Bruton's. And then again, with the innate ones, chronic granulomatous disease and Shirei-Kagashi are more of like these guys. Well, specifically neutrophils, but yeah, it's like an innate issue. Whereas the other ones are all your adaptive issues. Okay. All right. You're going to love that slide. You're going to love that next year. You're going to be like, wow. Okay. So anyway, the last thing before some questions are going to be important CD markers to kind of keep in mind and kind of start making flashcards now, just to kind of keep seeing it. And then what interferons are, because you keep seeing this term interferon. So I just kind of wanted to introduce that concept to you. I know it's a lot, but we're going to talk about some of these. These are just ones that I really think you really should know. Not all of them. Like, for example, I don't think you really need to know CD18. Like, I think you can figure out that they're not going to ask what is deficient in this. It's going to be more like, what is the deficiency? And it's LAD. But these are ones that they can just straight up ask about. So that's kind of what I was thinking of when I put this on here. So for B cells, and again, this is going to help you with cancer, I promise. It's going to help you with a lot of the cancers, because a lot of the cancers, you need to identify, is it a B cell cancer, is it a T cell cancer? So a lot of the times, like, you need to know, they're not going to say this is a B cell cancer. They're going to say it's a CD19, CD positive cancer. And you're like, okay, cancer of the B cells. I know what I'm working with. Okay. So if you have CD19 and CD20 on your surface, this is a marker of all B cells. This is just, you're a B cell. CD40, remember, that's on your B cells, and that's going to bind to CD40 ligand on the T cell. This is signal 2. If the B cell is acting as an antigen presenting cell, then CD86, 80, 86, B7, these are all the same thing. That's going to be supplying signal 2 for T cell activation if the B cell is acting as an antigen presenting cell. And this isn't just on B cells. Obviously, this can be on any of the antigen presenting cells, but it is one of the ones that's on a B cell. And then that one is specifically binding to CD28 on the T cell. And then CR1, we mentioned like very briefly, like back when we were doing complement stuff. But CR1 is the specific receptor on B cells that recognizes C3b. And not only CR1 is on here, not only is CR1 on B cells, CR1 can also be on macrophages. It can also be on red cells. Just if you see CR1, it's a C3b receptor. Does CD19 or 20 have a function? No. So they really don't have a function. They're just kind of markers of B cells. They probably do. They probably help with signal, like activation of B cells in some way, but for your intents and purposes of like doctoring, you just have to know that they're going to be good targets. Like, and I'm kind of alluding to some hemonc farm, but they're going to be good targets for B cell cancers. So you can just kind of target it, and then the B cell like can't proliferate. Yeah, no problem. All right, let's do T cells, because we just talked about B cells. So T cells, remember I talked about CD3. So CD3, when we talked about like CD4 and CD8, I'm like, oh yeah, CD3. This is on all T cells. So it's kind of the same idea as CD19 and CD20 on B cells. It's kind of the marker of all T cells. CD4, this is your T helper cell marker. CD8, this is your cytotoxic T cell marker. So CD25, this is your marker of regulatory T cells. So I think, though, more so what they're going to do for regulatory T cells, they're going to say like FOXP3, like rather than just CD25, but there's a reason I must have put it on here. So, yeah. But just keep in mind, right, Tregs. So Tregs are still T cells. They're going to have CD3. Tregs are still they're still T helper cells. They're going to have CD4. And they're also going to have CD25. And remember the transcription factor for Tregs is FOXP3. So these are all kind of ways that they can identify cells without telling you, hey, this is a regulatory T cell. They can just say CD3 positive, CD4 positive, CD25 positive, FOXP3, and you're like, but just keep in mind, like that's why we're going over these now. CD28, signal 2, binds with B7, 8086 on the antigen presenting cell. CD40, signal 2, B cell activation, binds with CD40 on the B cell. Okay, so let's go like this. So NK cells, CD56 is a marker of all NK cells, and this was kind of brought up in a question that we did back when we just talked about ADCC with NK cells. It was like 2 answer choices were like NK cell markers, and you guys were like, which one? I know it's an NK cell. But that was like a way to kind of be like, nah, it can't be an NK cell. These are both on NK cells. But regardless, we can go back and look at that question later. But CD56 is a marker of all NK cells. It's kind of like CD3 with T cells, CD19, CD20 with B cells. CD16, this is another name for the Fc gamma receptor. So you can even write Fc gamma receptor under it to be like, oh yeah, that's what CD16 is. And again, remember CD16, this is the one that, so if we have an infected cell here, so this is infected. Now we're going to have antibodies binding to it, IgG antibodies binding to it. NK cells can kind of come here, bind to the Fc portion of this IgG receptor of this IgG antibody. So it can bind to it with its CD16. And then this is going to be a trigger for degranulation, not really degranulating, but releasing its porphyrin and granzyme. And remember, porphyrin and granzyme, it's the same thing that CD8 positive T cells release when they're killing a target. That's why, again, NK cells and T cells are like, and CD8 positive T cells are like the same cell. Okay, hematopoietic stem cells. This is going to be helpful again for hemonc, but CD34. This is a marker of all hematopoietic stem cells. Again, kind of the same idea. Marker of all NK cells, marker of all T cells, marker of all B cells. CD34. And this, they actually will say CD34. Like, they will just say CD34 positive cell. And you're like, that's like a hematopoietic stem cell. That's a stem cell. It has not differentiated yet. So actually, is it on here? Yeah. So that would be like this. This would be CD34 positive. So if they're trying to tell you that a cell is like super immature to the point where it hasn't even like gone down a pathway yet, it's CD34 positive. Question, sorry. Is CD21 also on B cells? Yes, it is. Very good question. We're going to talk about it tomorrow with mono. But yes, CD21 is also on B cells. It's just not like it's more of like a marker for mono. I guess I could have put it on here, but we will talk about it tomorrow. It's how like the virus that causes mono, Epstein-Barr virus, it's how it, remember, actually, I don't know if we've ever talked about it, but oh yeah, we did. Epstein-Barr is dormant in B cells. It's where it like just likes to live. And it enters B cells via CD21. And the way you remember that is you have to be 21 to enter a bar, Epstein-Barr. And then remember with Epstein-Barr, so it enters B cells via CD21. But remember, the lymphocyte that reacts to it is your CD8 positive T cell. That's the reactive lymphocyte on the blood smear. Don't get that wrong. Don't get got with that. Okay, but we'll talk about that more tomorrow. But yeah, CD21 is also on B cells. That's how mono enters B cells and like lives there. I don't know why I put this. Recall stromal cells will not have CD34. I don't think we've ever talked about a stromal cell recall. So I think what I mean by this is just like, I don't know why I said recall, but stromal cells in general, stromal cells are like the cells that make up like tissues. So like when we were talking about like how like cortical epithelial cells present antigen to the T cell as it's maturing, it's just a cell that exists in the cortex of the thymus, right? That would technically be like a stromal cell because it's like that's where it is. It's like, so I think what I was trying to say is that like more mature like cells that are like epithelial cells don't have CD34, which is kind of obvious, but okay. So I did put that on here just for fun, I guess. All right, and then lastly, macrophages. So remember like day 1 or day 2, I said you should know the toll-like receptor that recognizes LPS. Well, here it is again. So it's TLR4. It recognizes LPS. So this is the pattern recognition receptor on macrophages that recognizes LPS. Another name for it, CD14. just because they love to have us memorize random numbers. I'm not sure why. Remember, macrophages have Fc gamma receptors. I think I tried to put gamma and it just didn't come through. But Fc gamma receptor, and it binds with the Fc portion of IgG. It also has a CR1. If you also want to make a little note, like red cells also have CR1 just for completeness. I think those are the only cells that have CR1 receptors, is your B cells, your macrophages, and your red cells. And then lastly, macrophages can also have signal 2. So can dendritic cells, all of the antigen-presenting cells. So here's one antigen-presenting cell, here's the second. Dendritic cells would also have CD8086 or B7 on its surface, binds to signal 2 on T cells. And then this isn't in your notes, but I went back to my notes because I remember I spent excruciatingly long making like a beautiful macrophage with all the receptors on it. So here's my beautiful macrophage. So I wanted to put this on here just to kind of help you guys like visualize all the things and then all the cytokines that it can release and its functions. So macrophages have FC, oh my God, I did it again. Fc gamma receptors. This one was on me though, I just didn't put it in there. So Fc gamma receptors recognize the Fc portion of IgG. It has its C3b receptor, which I conveniently forgot to call CR1. So CR1 recognizes C3b. This is important too with like getting rid of antigen antibody complexes, because remember, here's your antigen, here's your antibody. Oh my gosh. And remember, in that Fc portion of the antibody down here, there's the complement binding site. So this is where like C3b would be bound. So this is basically how macrophages remove immune complexes. They bind to C3b. So they basically bind to like opsonized immune complexes and then take it to the spleen and be like, hey, remove this. So then up here, it has MHC class 1. So if it gets infected, it can put antigen on its MHC class 1 to find a CD8 positive T cell. It upregulates B7 or CD8086 for co-stimulation. If it's acting as an antigen presenting cell, it can upregulate, it can put antigen on its MHC class 2 to interact with the CD4 positive T cell. Or if it itself is trying to get activated, signal 1 is going to be one of these two. Oops, nope. Is going to be one of these two. So either MHC1 or MHC2, but also remember coupled with the being bound by cross-linking by the receptor, because you still need to do this to have the macrophage take it in. Oh no, I'm thinking of B cells. Oh my God, sorry. Sorry. Signal 1 is either going to be this or this. Here's signal 2, CD40 ligand. And then lastly, we have CD14, aka TLR4, at least there's 4s. And this is going to recognize pathogen-associated molecular patterns, PAMPs. So LPS is a good one. Well, LPS is specifically the one for CD4, CD14, or TLR4. But it has tons of PRRs. Like there's PRRs all over the surface that all recognize different things. Some recognize single-stranded RNA and whatnot. So it can recognize PAMPs. And then this terminology was in first aid. I've never heard of this, but I guess I put it in here. DAMPs. Damage-associated molecular patterns. And I think what they were trying to say is that like macrophages can also recognize like your own tissues that are dying, because they can go and clean it up, basically. That's what macrophages do. They're kind of like the garbage disposal. So they go, they eat it up, and they're like, all right, let's get rid of this for you. So they're not really like pattern. Sorry, oh my God. They're like patterns, like they're specific like patterns that are associated with necrotic tissue, but they're not from pathogens. So they call them damage-associated. It's silly, but okay. And then here are your cytokines that are important that macrophages secrete. So IL-1 is like the main one that's important. And remember, this is what helps with a lot of inflammation. So in hot T-bone steak, this is what causes fever. Well, it helps with fever. It's not the only one that causes fever. But I put on here a lot of the other things that it does. Another one, remember, it upregulates ICAMs. That was like one of the questions that I had brought in about IL-1. So it upregulates the ICAMs on the surface. So like with the rolling and diapedesis and whatever of neutrophils, it can help with that process. TNF alpha. TNF alpha is really important for granulomas. So it's really important to maintain your granulomas, but it also helps with some others. It's a pro-inflammatory cytokine, so it's going to also help with fever and whatnot. And this is the cytokine responsible for cachexia. So that terminology that just means like kind of like literal wasting away. I did look into it, by the way. I remember there was a question like, well, what causes that? And I think TNF alpha, it increases the utilization of lipids or something. So you're basically like really getting rid of all the lipids in your body. So you kind of waste away in that way. So that was just a fun fact. You don't have to know that. It's just like if they say patient is cachectic, what is the cytokine responsible? TNF alpha, always. IL-6, this is really more of your fever. This is also your acute phase reactants. So remember in the hot T-bone steak, this is K for acute, but it's K instead of C. IL-8, clean up on IL-8, and then IL-12. This is the one that can also help with Th1 cells, also help with NK cells. Remember in that slide where IL-12 receptor deficiency, that was any antigen presenting cell can secrete IL-12 to increase both Th1 cells and NK cells. We didn't really talk about that, but I do know that there's a slide describing this in the innate lecture. So it's also something that does that. And then lastly, before some questions, so type 1 interferon. So we are talking about interferon gamma a lot. I think that's the only interferon we talked about. There's also what are known as type 1 interferons. So type 1 interferons, interferon gamma is not a type 1 interferon. Interferon alpha and interferon beta. These are the only two type 1 interferons. And what these do are these are like an innate antiviral response. They're pretty cool. So when a virus basically comes in and infects you, again, viruses need cells to replicate. They can't replicate without cells. So what they do is it kind of like these cells are able to like sense that it's been infected by a virus, and it kind of accepts defeat. It's like, you know what? You're already here. I'm going to just let you replicate, and then you can kill me and then leave and go infect other cells. But it's like, you know what? I'm gone, but I'm going to help protect my neighboring cells because it's a good cell. It's an altruistic cell. So it gets infected. The cell senses that it's been infected by a virus. So it secretes type 1 interferons. So interferon alpha and interferon beta. So when it secretes type 1, what these type 1 interferons do, and they do try to help save the cell from the virus, but usually it can't. But what they do is they help the neighboring cells. So the neighboring cells get this type 1 interferon. It upregulates transcription of certain genes that now put it in an antiviral state. It's really cool. So think of it as being like on high alert now that there's a virus on the loose. So it was basically like how the cell told it, like, yo, there's a virus going around in the neighborhood and sneaking into everyone's house. So what it does is it's like, he got it, like turns on the alarm. It like gets a bunch of guard dogs. It like locks all the doors. That's like what the antiviral state is. It tries to prevent these viruses from now entering into it and allowing it to keep proliferating. It's good. It's like an antiviral innate response. It's kind of cool, but it's not always that great. But a lot of the times this stops viruses from proliferating, because even if one virus enters your cell, it's not terrible. What gets really bad with viruses is when they keep proliferating. Like this can go infect a cell, then this can go infect a cell, then this can go infect a cell. All of them can make like 10 more viruses. And that's where you get like the cells can't keep up. They're like, oh my God. So this is kind of like an attempt at stopping them from even going through that process. Okay. Type 1 interferon. So I don't think there's going to be something about that, but if you see like type 1 interferons in a question, or like interferon alpha or interferon beta, that's not interferon gamma. It's like a totally different type of thing. They're both a part of the innate immune system, but totally different function. Interferon alpha and beta are specifically for viruses. It's like, again, inducing this high alert for viruses. Whereas gamma is like more for mycobacterium infections, making macrophages really good killers. So they're a little different. Okay, you guys ready for some questions? I'm just going to say this before you guys keep going. There's a trick to answering this question correctly. You guys are like split 50-50. There's a trick. There's something in here that you're going to be like, ah, I missed that. There you go. Okay, let's chat. You guys are still working, no worries. I'll try to speak a little to give you a little more time, but I know, again, I know that these are long. I know that these are, yeah, so I know that these are long. So the trick with this question, almost all, I think all of you are split. Yeah, all of you guys are split between A and B. Awesome. So I don't know what SAP is, so that's fine. We'll get rid of that. It's not Wiskott-Aldrich. Remember, you need that triad. And it's not this ICAM1 deficiency. We didn't talk about this, but think of it as like an LFA1 deficiency. It's kind of like the same idea. So ADA deficiency causes SCID. So it's one of the causes of SCID. And then this one, the BTK gene defect, this is your Bruton's. So remember with Bruton's, you don't get antibodies, basically. That's what it is. SCID, you don't get antibodies and you don't get T cells. So how do I know that, actually, if you guys are still working? So let's go through this before I give away the answer. So patient has an infection. Okay, fine. Has similar bouts of bacterial infection in the past. Okay, so recurrent infections. Okay, so we're dealing with an immunodeficiency question, maybe. The trick with this is he had recovered, what does it say? Uneventfully from measles 6 months ago. He's recovered from a viral infection, had no issues getting rid of this viral infection. Do you see? So kind of some of you guys are like, well, it can't be that because he was infected with the virus. He recovered from a viral infection and it was totally fine. Anyway, no palpable lymphadenopathy. Okay, it can be B or T cells. Subnormal levels of gamma globulins. Now we got no gamma globulins, but again, that can also happen with SCID, right? And then MBT, normal phagocytic activity. So we know it's not going to be, because we know that this is catalase positive. So we know that this is not going to be one of the CGDs. So this is Bruton's. And basically that's how you go about this. If you're between SCID and Bruton's, where it's T and B cells, and then Bruton's is basically just B cells, there's got to be something in there that's going to help you identify between the two. And then look for recovery of viral infections. You need T cells to get rid of virus. You need them. You absolutely need T cells to get rid of viruses. So if this patient did not have T cells, there's no way they could recover from measles. It's not like bacterial infections where it's like, yeah, eventually you'll get better. Like eventually you'll just keep getting them over and over again. With viruses, you need to, if you don't have T cells, like the virus is going to kill you. It's going to keep replicating. The type 1 interferon response is not going to be able to keep up. Okay. And that's kind of what it's saying here. Which the answer choice for SCID is not very helpful. It's like, there would be signs of T cell defects. You're like, thanks. So what are they? But the other thing too is like, look for, I think, did it say in here, bouts of bacterial infection. So they were just trying to get at more that this is like a bacterial thing, which is really what you need your B cells for. Does that make sense? So I'm glad though some of you guys got so we could talk about it. But just keep in mind there's got to be a way to differentiate when you have two options like that. Okay. Okay, cool. Next. Okay, I think I'm gonna go do this one now instead of 90 because a lot of you guys have already answered. Um, so this one, um, okay, white discoloration of the tongue, recurrent episodes over and over. Sounds like a chronic condition, right? She's only 15. She's had them for the past 5 years. Sounds pretty chronic to me. Then she's got white plaques they scrape off. Cool. And then potassium hydroxide, budding yeasts. This is chronic candidiasis. And my D people, my people that pick D, I definitely caused the foible. I definitely caused you guys to pick D. So we're gonna talk about how that would look. There is forms of candida infection that you need neutrophils for, but chronic candidiasis, exactly presenting like this, is you need T cells for it. But we will talk about the neutrophil with candida tomorrow. Okay. Okay, that was 90. So for this one, the people that got this one wrong, you at least were in the ballpark. So you knew, which I'm very proud about. You guys knew that this was catalase positive. You knew that this was catalase positive. So you're like, okay, I'm thinking CGD, right? Hopefully. But you're like, okay, recurrent infections with these catalase positive organisms. So now it's like, all right, it's got to be one of the ones in that respiratory burst pathway. And then you look and you're like, oh man, there's three that were in that pathway. You're like, oh no. But specifically, and this is kind of where like technically any of these would be, well, any of these could be defective technically, and it would cause the same symptoms. But CGD itself, the actual condition, is an NADPH oxidase mutation. So that was kind of like the yeah. So I liked this question to be like, if to show you kind of just to remember, like it's specifically that enzyme that's causing CGD, that's specifically mutated. Okay. Okay. Next. All right, that was about 90. Get your answers in. Okay, so for this one, what kind of so again, repeated episodes of bacterial infections really doesn't help us. We can so this one has CVID as an option, so we can look at the age. That's kind of like, all right, let's look at the age. 14-month-old, probably not CVID, because again, remember, CVID happens after puberty. I never say never in the body, because the body's crazy, but usually in prompts, at least in vignettes, it's not going to be CVID with the 14-month-old infant. So with this one, the trick to this one was trying to figure out which one this one is. So this, I don't really know why they said pokeweed mitogen. I don't even know what that is. I think they're just saying like an antigen in general. But regardless, this was your key. Bone marrow aspirates are remarkable for hypercellularity of pre-B cells. Remember the one that affects B cell maturation to the point where the B cells they themselves get to a certain point and then they don't mature any further? That's going to be Bruton's. So remember with Bruton's, go back to that like summary slide I gave you and look at where that X is in the pathway. It's going to be like right after the pre-B cell. And it's just basically like that's what's happening is like the bone marrow is going to have tons of B cells in it. It's just they can't leave. Like they just can't get to the peripheral blood. And that's why it's saying the peripheral blood shows an absence of cells that are responsive to this antigen. So there's no B cells in the blood, but there's B cells in the bone marrow. That's Bruton's. Okay. And some of you guys picked selective immunoglobulin deficiency, which I get because again, it's like you don't have B cells, so it's like you don't have immunoglobulins. But with this, really the key was the B cell development. That has nothing to do with B cell development. Oh, interesting. Pokeweed mitogen is a B cell mitogen. Well, that would have been good to know. All right. CD19 positive cells will be absent. So that's another way they could have said that. There's no CD19 or CD20 positive cells in the blood. Okay. All right, let's rapid fire these. Okay, that was 90. This is a tricky one. I'll give you guys this one. But, so with this one, this is why I said it's really good to kind of, and again, I know you guys just learned this like today, like 2 hours ago. But what's a good thing to do and good practice is establishing, is this an innate issue or is this an adaptive issue? So what in this tells you that it's going to be an adaptive issue is this absent thymic shadow. Boom, T cells. There are no they're giving it away. They're giving it away that it's T cells are going to be involved. So then what you do is you go through these when it gives you like mechanisms, you're like, okay, what is this one talking about? Abnormal actin polymerization. What is this one talking about? What is this one talking about? What is this one talking about? What is this one just go through and be like, these are what these disorders are. And the only ones that have anything to do with T cells are B and C. Those are the only ones. This one, the actin polymerization, that's going to be what's the, oh my God, I'm already forgetting. Thank you guys. Thank you. Wiskott-Aldrich, right? Is that the one? Yes. Yes. So that's going to be Wiskott-Aldrich. Neutrophil oxidative versus your CGD. Microtubular dysfunction. This is going to be your Shediac-Higashi. So these are all innate. if you go back to the notes, these are all innate. So like the Wiskott-Aldrich, that's going to be more thrombocytopenia, which is like they would say something in here about bleeding. Well, I guess it does say bleeding, but like that would be the focus. It would be like there's just bleeding every single time he gets cut, he bleeds. Things like that. This is trying to say like there's these rashes that he has is a little, or this boy has, are a little bit more than just something you can scrape off. I think that's what they were trying to say, it was bleeding. But it's a good distractor for sure with thrombocytopenia, but this is not how thrombocytopenia presents. Yes. Yeah. So this is not how it presents. This, I'm telling you, look for things like this. Absent thymic shadow, no T cells, cross off anything that has nothing to do with T cells. So for this one, chromosome microdeletion, this is going to be your, like, a part of the catch-22 mnemonic. That's what the 22 is. So 22 is the chromosome. Q11 is the microdeletion. So this is your DeGeorge. I'll just do DG. Cytokine receptor deficiency, they're either talking about IL-12 or IL-2 receptor deficiency. IL-2 receptor deficiency can cause SCID. And remember I said it's kind of hard to identify how like failure to thrive will look in a question. That's why I put this one on here to kind of show you they're talking about failure to thrive. So look for things like when they talk about height and weight, like what percentile they're in for height and weight. That's usually how you identify failure to thrive in a baby. Is like they're not eating, they're just not doing well. They're sick all the time, and they're small. So like that's why like third percentile for height and weight is like, okay, failure to thrive. So this is SCID. Oops. Okay, so this is and with cytokine receptor deficiency, IL-2, it's specifically IL-2. That's why this is a little trickier. Would IL-12 receptor deficiency still have a normal thymus? Yes, because you still have T cells. Sorry. You still have T cells, you just can't activate them to make Th1. So it's more so like think of IL-12 receptor deficiency as more of like a Th1 T cell deficiency. So like macrophages aren't doing what they're supposed to be doing. You get tons of mycobacterial infections over and over and over again. IL-2, and I know it's tricky because they both have 2 in the name, right? But IL-2, SCID. This could have also been like enzyme deficiency. So like ADA, adenosine deaminase, that's an enzyme. It could have also been like VDJ, like enzyme deficiency. RAG is also like the gene coding for a protein, whatever. That's RAG, that can also cause SCID. So it's tricky. Flashcards are going to be important with these, but I really wanted you to see how they would like present failure to thrive. This whole vignette is like failure to thrive. Tons of infections in the lungs, in the GI tract, fever, tons of just weird stuff going on with the skin, really tiny baby. That's your failure to thrive. Okay. Okay. Cool. Very good. Okay. 90 seconds. All right. So this one, not gonna lie, as soon as I opened this question, I was like, umbilical cord, they've got to be talking about LAD, right? But we're good students, so we read the whole question and we don't knee slap, pick an answer. So baby, 1 month old, still has an umbilical cord. That's weird. It's like, that's weird. But anyway, going through, it just sounds like he's got tons of infections going on. Non-purulent ear discharge. Remember what usually causes pus are neutrophils, usually. Like if you have pus, it's usually because of neutrophils. PMN, pus. Because that's all pus is, it's dead neutrophils. Anyway, other stuff going on. So the umbilical stump is erythematous and indurated. So clearly didn't like fall off gracefully. And then the leukocyte count is high. So high white count, 90% of them are neutrophils. So what's acting like we have low neutrophils with a high neutrophil count is LAD. So this is LAD, and which one of these describes LAD is neutrophil migration. So again, like your neutrophils are fine, but they can't get to where they need to go. And everyone that answered got that right. I'm very proud. Very proud. Okay. But here's this. And they talk about CD18, which is also the type, like the LAD one. Yeah, technically you're right. Technically it is specifically adhesion. But it's like, I guess Dr. Ryan is just basically saying like migration in overall, like this whole process of migration requires functional adhesion molecules. So I guess migration isn't done until it actually physically migrates out of the cell. Sorry, out of the blood into the tissues. I think that's probably what he's getting at. Okay.
I just have a question for you.
Yeah.
The only thing that confused me was the like pus coming from the ears essentially. So it
Mhm.
was like, how are you getting that pus from the ears if there is like essentially the neutrophils can't migrate there?
So you're not getting pus, so that's what non-purulent means. So non-purulent,
Oh, non. I missed the
the
non. Thank
key,
you.
the keys. Yeah. Yeah, exactly. Yeah, you would have been 100% right. If this said purulent, you'd have been like, that can't be LAD. So think of this as like a watery discharge, non-purulent. So that's like another key, like, oh, like another clue, like, oh, there's no neutrophils there.
Thank you.
Yeah, no problem. But interestingly, what's kind of cool, so special note, I didn't put a box around this, but Dr. Ryan's right. In actual practice, the most common reason for delayed cord separation is excessive cleaning. So using tons of alcohol. So if you're using alcohol to try and clean it, to keep it all nice and clean, like the stump, that prevents the neutrophils from getting there because alcohol gets rid of bacteria, right? So they can't get there, and then that causes delayed cord separation. But in vignettes, you can assume that it's because of LAD deficiency. Okay, next. Okay. 90 seconds. Again, if you're not getting like to these, like you shouldn't be getting to these that fast. So don't feel like you like yeah, you just did these today. So don't worry about it. That's why I give you guys the questions later. But anyway, we have this baby. No, sorry, we have a 4-year-old. Okay, he's got tons of infections. Okay, so 1 year he grew Staph aureus. What's Staph aureus? It's catalase positive. Think of a little cat. Next time he's got aspergillus. Oh, another catalase positive organism. Okay, And then they even tell you that they did dihydrorhodamine and it was negative, no color, no fluorescence after stimulation. So this is CGD. So this is CGD. They just tell you this with basically the dihydrorhodamine. If this said nitroblue tetrazolium, that would also be diagnostic for CGD. So for CGD, remember you can't do respiratory burst. And which of the cells does respiratory burst? Your neutrophils, your PMNs. Okay. Again, if you were like, I forget, but I know it's an innate cell, that's fine. You got like you would at least could rule out this, this, and this. You could have at least ruled out 3 answers. So that's good still. Okay. That's pretty much it. It's like, yeah. Yeah, I think I did put it on there, but macrophages technically also can do respiratory bursts. It's like, but you never hear about it. It's always going to be your neutrophils. But just keep in mind, this also could have said macrophages. That also would have been correct. But just keep that in mind. I think I did put it on the slide. If I didn't, I'll add it before I send it back out. That'd be extra tricky, but I don't think that they would do that. Okay. Okay. Let's go over this one. Okay. 3-year-old, blah, blah, blah. Infections, of course, blah, blah. Okay, so 6 months ago, she developed diarrhea and was treated for giardiasis. That is interesting. Giardiasis. Okay, blah, blah, blah. And then lab testing, absent serum IgA with normal IgG and IgM. When you see like this, like absent serum IgA, just make sure they're not being mean and saying like also with absent IgG, IgM, IgD, because you don't want to like get got, so to speak, with like hypogammaglobulinemia. So sometimes they'll just do that to be annoying. So just make sure when it's absent serum IgA, the other ones are normal. Just a little tidbit. So for this one, like I said, if you have absent IgA in the future, you're usually going to be transfused with blood that has IgA in it, hence anaphylactic. This is your type 1 like transfusion reaction. It's literally like allergic slash anaphylactic. So IgE mediates this reaction, but it's because of anti-IgA antibodies that you had made. And then you get degranulation. Okay, good. Okay, that was 90. Um, so lots of answer choices here. I know. A lot of the boards questions will give you like down to like option like H. You're like, oh my God. But anyway, you won't have this many options on your test. So, but regardless, the key here, so you don't have to know acid fast, like what this means, and that's why I told you it's just mycobacterium. So basically it's saying like this 2-year-old, she came back from this trip and now she has mycobacterium infection. So this was basically, this was like a, not a, I wasn't trying to be tricky on purpose, but if you think of this as being like an IL-12 receptor deficiency, if you don't have IL-12 receptors, you can't make Th1 T cells. If you don't have Th1 T cells, you're not going to have interferon gamma. So decrease interferon gamma levels. That's what you need to get rid of mycobacterium. Makes sense. And that's what I kind of tried to put here. Like IL-12 receptor deficiency, again, just I think just seeing this process over and over again is going to help. So again, IL-12 is from the APC. The APC secretes it and it tells this naive T cell like, hey, upregulate T-bet and become a Th1 T cell. Th1 T cells release interferon gamma, which activates macrophages. You need activated macrophages to get rid of any type of mycobacterium. So it was a little tricky because they didn't give you much on IL-12 receptor. Like it didn't say recurrent, mycobacterial. It just was like the one time. But that was like the only one that kind of made sense with this because of this. You need that to get rid of mycobacterium. And she has like this mycobacterial infection. Just tried to like show another way that they could ask without specifically asking about the receptor, like on the T cell. They could ask about something downstream of the receptor. Like you're not going to have that now because this is not happening. All right. Okay. Coming up on 90. Um, so just a trick for questions like this. So see how it says like the boy's uncle had a similar condition and died of an infection at an early age. This is like classic ways that these test writers ask about X-linked, tell you it's an X-linked recessive something. And you're gonna see this a lot in hemonc. It's always like if they're trying to get at one of the ones that's X-linked recessive, they're gonna say the boy's uncle also had this because they're trying to say it's like maternal, right? It's on the maternal side. So anyway, that's just like a little tidbit. But for this, how you kind of answer this, so tonsils are barely visible. Okay, it's either B or T cells, right? So B or T cells is that low CD19 positive B cell count. There are no mature B cells in the blood, basically, or they're low. T cells normal. So remember, this is basically Bruton's or X-linked agammaglobulinemia. And with that, remember, they stop maturing in the bone marrow. Sorry, I should give the answer. They stop maturing in the bone marrow when they get to the pre-B cell. That starts like that's the only one that's going to be in the bone marrow, the pre-B cell. There's not going to be any mature B cells in the peripheral blood. Okay? So, like failure of phagolysosome formation, these are all just kind of like dysfunctional cytokine receptor. That could be IL-2, IL-12. Cell migration, they're talking about the neutrophils again. Phagolysosome formation, this could be the microtubule ones like the Shiraya Kagashi. and whatnot. Oh yeah, sorry, I missed one. The this one can be for the Wiskott-Aldrich, which I don't even know if we talked about. But regardless, X-linked, B-cell maturation, BTK gene, Bruton's, all that stuff, that's going to be this is like kind of classically how it presents. But look for patient and uncle. They always do that. Okay. Just a little review from yesterday. I'll give you guys a minute for this one. Okay. So with this one, it's just a straight, which type of transplant is this? Heterograft is not a thing. So this is not a type of transplant. These are the four. So autograft, you take a part of your own self and you transplant it into yourself. That's not happening here. Xenograft from an animal. So a lot of the times it's going to be like a pig valve, like aortic. If you have like aortic stenosis, that's going to be like your xenograft. Now we're with like allograft and isograft. So kind of like the way to answer this is he's got a twin brother, but it doesn't have to be an identical twin. It can be a fraternal twin. But it tells you he's HLA identical. So when they say this, you're assuming at this point the organ is identical. They're identical twins. So in this instance, it would be an isograft versus an allograft, which is just you get a transplant from just any person of the same species. Okay. So that's kind of like HLA identical. Remember, HLA genes are what code for MHCs. So this is basically saying like his liver or whatever has all the exact same MHCs as his brother. So it's an identical match. They're identical twins. And then it's kind of what it says here. And then, yeah, it even says it in here. In reality, even identical twins are not really identical, but it's better. It's the best type besides an autograft. It's the best type. Okay. Two more. Immunodeficiencies are asked so much. I just really wanted you to see some good ones. All right, 90 seconds, get in some stuff. All right. So a lot of you guys, I'm gonna say it, you got. But it's good. We're gonna talk about it. It's kind of my fault. I made you peer back to the depths of your mind. But a lot of you guys went with CVID, which is good. You went for the age, which is good. It's not age is gonna rule these guys out to me. Actually, not really selective IgA because you don't really know about selective IgA. But selective IgA, regardless, they'd have to talk about Giardia, they'd have to talk about transfusion reactions, they'd have to talk about something like that, which they don't do. Out. But these guys would present early in life. Out, out. It's not CVID. CVID, I know I did say it presents it's very weird how it presents. It's different, it's variable, right? But if you have 4 episodes of Neisseria, you're getting Neisseria over and over and over again. Do you remember what type of deficiency we talked about causes Neisseria over and over and over again? A terminal complement deficiency. So terminal complement deficiency, remember that can be anything from C5 all the way to C9. So C5, C6, C7, C8, it could have been any of those as this option. I'm sorry, I know I made you peer back to the depths, but I wanted you all to pick A. That's why I put this on here. To also not be like, ooh, age 31, it's gonna be CVID. A lot of the times it's not a bad strategy if these were all, ones that presented early, like as options. But disseminated Neisseria 4 times in a row is it's only Neisseria. It's less of like a C3B issue because like Neisseria is encapsulated. But if you only keep getting Neisseria over and over again, that's really going to be like a late complement deficiency. And I really truly think a lot of the times the late complement deficiencies will present earlier in life, but I think they did this on purpose to get people to pick A. Like I really do think they did this. Okay. And then let's see what they say about this. Okay, so CVID condition appears late teens. Yeah, think like puberty. I mean, 31 wouldn't be totally off from puberty. I say that to make myself feel better. No, but it really would be like late teens, early 20s, but they don't even say how it causes because they just don't really know. Like they don't really know. It's so different every single time. But again, I'm just trying to show you patterns. Like if you're reading this, you see like Neisseria over and over again, late complement deficiency. Okay. Very cool. All right. One more. Oh no, one more. 2 more. Okay, let's chat. You guys are getting tired, I can tell. I'm sorry. I just get so excited about immunodeficiencies. They're so fun. Last one after this one though, I promise. But do these again once you start to get like a good grasp of these. These are like how they will be asked if you were to get an immunodeficiency question. These questions are how they would be asked. But anyway, let's kind of skim very quickly. So we see sputum culture causes, and it's a young boy. Okay, sputum culture shows Burkholderia cepacia. Remember, this is one of those catalase positive organisms. I know, it's like the weird one. So Staph aureus, Aspergillus, Burkholderia, Serratia, Nocardia. Those are the 5 you must know. Come up with a mnemonic. Do what you got to do. Again, there's a lot more. There are a lot more catalase positive organisms, but these are the ones that are usually going to be in vignettes for CGD specifically. And then they tell you, and it's kind of weird because they don't tell you like recurrent, like it doesn't say like, oh, staph, then Burkholderia, then, but you can assume because it's like they keep saying like recurrent infections, they just don't tell you what those were. But what they do tell you is they tell you about, they did the NBT test. So they did nitroblue tetrazolium, and look at that, neutrophils remain colorless. So it's a negative NBT test. So this is CGD. diagnosed. Once you do the test, it's diagnosed. And then now it's back to what's the mechanism of CGD? CGD, NADPH oxidase is defective. You can't turn oxygen into superoxide. B cell maturation, they're talking about Bruton's again. Microtubule polymerization, Shiraya-Higashi. T cell CD40 ligand is going to be your hyper IgM, and then actin filaments is your WAS. WAS. No. Yes. No. Yes. 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 Okay. So again, and then this is CGD. So just kind of like, again, like do this as much as you possibly can. Like when you go through all the options, write out what it is. Because the more you see it, the easier it's going to get to be like, okay, I know what they're asking about. Like I know what's going on with this. I know how it should present. But again, CGD, they tell you with the NBT, NADPH oxidase. And then I kind of put this on here again, just to remind you to definitely try and know these 5, at least for your exam, for sure. Yeah. Okay, one more. Little review. Okay. Let's chat. All right. So it'll be good to do a little review of what's happening, the type 4 that's happening here. So with this, patient has poison ivy. So we know that this is type 4 hypersensitivity. We know T cells are going to be involved. Okay. So remember the T cell gets activated, and then what causes like the induration, the itchy lesions, like what causes these lesions is the development of all these cytokines. So the Th1 cells activate CD8 positive T cells, the Th1 cells activate macrophages, activate all sorts of different types of cells to start secreting pro-inflammatory cytokines. That's why you get itchy, and that's what happens. So what they're saying though is what can they administer that could inhibit the severity of this reaction, aka inhibit all of these pro-inflammatory cytokines. So this question was a fancy way of asking which one of these down here is an anti-inflammatory cytokine. You guys all better know this for your exam. There's 2 anti-inflammatory cytokines that you absolutely need to know for life, and it's going to be IL-10. Does anyone remember the other one? Okay, good. Good. Yes, good. Okay. There you guys go. All right, yes. TGF beta. Whenever you see TGF beta and IL-10, you need to think anti-inflammatory, toning down the immune response. So this was basically saying like, hey, here's like a pro-inflammatory process. What can tone this down? Which could inhibit the severity of this reaction? And the only one that's anti-inflammatory is IL-10. IL-8 will recruit more neutrophils. That would make it worse. IL-3, a hot T-bone, that would stimulate bone growth. No. IL-2 would stimulate more T cells. That would also be bad. But I get why you guys would pick this, because like if you're thinking about poison ivy, you're like, oh, we need T cells. But we're looking at what can inhibit that reaction. And then gamma interferon kind of the same idea. It is Th1 cells, but again, that would activate macrophage. That would increase the amount of cytokines in the area. Because then when interferon gamma activates the macrophages, they just secrete more cytokines. They just kind of get more revved up. So again, that's kind of like another way that they can ask, which of these is anti-inflammatory? But yeah. And then it goes into like a little bit more detail than you really need. But that's kind of the takeaway. Okay. Wait, this. Stop recording.